Michael, thank you very much for this very, very kind, exaggerated introduction. I'd like to thank everyone who is persisting to this late time. You have just my lecture and one more, probably even more exciting lecture before this wonderful Congress comes to an end. My task of going over this subject, I think, is burdened by the fact that really it's a complex subject, it's hugely important, and could easily be the focus of a seminar by itself. But I will try to give you a little bit of the background, the rationale, describe some of the tools that are in active use and the tools that are in use in trying to optimize quality of care in congenital heart surgery, and some thoughts about the direction this is going in the future. Now, when we take care of patients, usually their children and their parents and the patients themselves, when they're old enough, reasonably expect that the treatment provided will be in appropriate facilities by objectively documented experts, by individuals who care, who work as a team, who tell the truth, and by individuals with whom they can have a relationship of trust. And I think these, many of these were broken down in the Bristol affair, which is very well known to the congenital community and especially to our colleagues from the UK here. Everyone knows that it was in the 1980s. It started when in the Bristol Infirmary there was excess mortality for a couple of procedures which were being more promoted at the time, more in favor of the medical community, the arterial switch operation and repair of the AVSD. Mortalities were remarkably in the range of 50 to 60%, at a time, I should say, when the arterial switch operation was in its early days and even in very capable hands all over the world had a mortality of maybe 10%. So it was an innovative type of procedure, but mortality was more than what surgeons and colleagues knew was going on around the world. However, there was concern by team members, but it was not formally addressed or effectively addressed within the hospital. And as a result of that, results eventually leaked to the press. There was eventually a public inquiry. It cost millions of pounds, and surgeons were fired. But this problem had, as a result, the introduction of monitoring of results and public reporting. So there were some very positive lessons from the Bristol affair. First, it has been firmly accepted what we always knew, that patients and their families have the right to know the outcomes of the treatments that they will receive. And also that it is our professional responsibility to share this information with patients and families in a format that they can understand, not in a very complex format, which is medical jargon, not understandable by patients. And of course, when we inform our patients, we must know our own mortality and our own complication rates and those of our colleagues. Otherwise, it is not possible to obtain informed consent from patients. And I would also like to say here that in my experience on both sides of the Atlantic, in various congenital units, and I'm sure this is true everywhere, everyone wants to provide the best possible care, and everyone really strives for excellence. However, it is also true that every surgeon thinks that his patients are different. And it is also true, Richard Feynman is a Nobel Prize laureate, theoretical physicist from Caltech. And of course, he was talking about different things, but he said that the first principle of science is that you must not fool yourself, and you are the easiest person to fool. So we have a moral responsibility for quality medical care. We are sworn servants of our patients. We have the responsibility to provide them with the best possible with minimal harm, and to provide the results of our treatments accurately, reliably, and transparently. And in the days of all the technology available, there is no excuse not to do it. And in fact, I believe that this should be compulsory. So when we talk about value-based medical care, we always talk about the ratio of quality versus cost. And clearly, there is very frequently, especially by politicians, let's see if this, cost is always very popular, and people focus on cost. There is less focus on quality. Now, there are three aspects of quality: structure, process, and outcome. And I will try to go over each one of these and go over what has been more or less accepted in our field. Now, regarding structure, the structure of congenital heart surgery programs. Obviously, there are regional differences, but at least in Europe, 20 plus years ago, the EACTS and the European Congenital Heart Surgeons Association put together a manuscript published in the Annals on the optimal structure of a congenital heart surgery department. And this document talks about the optimal being one unit for every 5 million people, so that it can do 250 cases a year split between two surgeons, with the caveat that the aim is not size but quality, and that size is one of the ways of trying to ensure quality, because we know that units of suboptimal size may indeed produce excellent results. There should be a dedicated operating room, ICU and ward dedicated to congenital heart surgery, PEDS and cardiac anesthesia, PEDS cardiology, all the usual things that we know, including ECMO and VAD support and transplant preferably, and also provision for care of adults with congenital heart disease. And in addition, a good unit should have programs for education, training, and research, and the center and the surgeons should be certified and recertified. So this is what the specialty feels is an optimal structure. Now, what about the process? Winston Churchill said that however beautiful the strategy, you should occasionally look at the results. So we should have a multidisciplinary team approach, and that's well accepted. It's been stressed many, many times during this conference. The program should have a morbidity-mortality conference where errors or problems are identified, recorded, and remedial action must be implemented. And of course, this should all be done in the context of participation in a national or even an international database. And this brings us to the third aspect of quality, which is outcome. Outcome depends on data. Without data, you're just another person with an opinion. And if you can't measure it, you cannot improve it. So we need a systematic recording of patient characteristics, procedures, and outcomes. That's data. We need a mechanism to ensure that the data are complete and truthful, and that requires independent data verification. And then we need objective data analysis. Now, the requirements for collecting and analyzing such data is that we should have a common nomenclature so that we can describe in the same words the diagnosis, the conditions, the procedures, and the outcome parameters. In the EXA congenital database, which has been now in its 26th, I think, or 27th year of operation, we have employed in harmony with the STS database in North America a common nomenclature which in its most recent iteration is the International Pediatric and Congenital Cardiac Code, which is ICD-11. So we have common data fields collected, a software platform, and analytical tools for risk adjustment and objective analysis. And we have developed specific outcome parameters and quality measures. I'm very happy to announce here, many of our cardiology colleagues already know that beginning with this year, the EXA congenital database, which is the registry of congenital cardiac surgical procedures in Europe, now has an official partnership with the AAPC and will include information, data on interventional procedures submitted by participating interventional cardiology AAPC centers. So data accuracy and completeness is of course important because in data science we all know if you put garbage in, you'll get garbage out, so the data must be complete. Data submission, I think, should be compulsory, but of course in Europe it is not possible across Europe. In the UK, of course, it is, and our UK colleagues know that. EXA uses a source data verification program, which means that inspectors from the database visit the participating centers and verify the submitted data. And I know Joachim Berlin is a participant, and frequently Zdislav Toboda or someone from the database would go over and verify the data. On the right side is a list of participating centers that have been verified over the last few years. There has been a little bit of a difficulty in the verification program because of COVID, but it has started again. In the arrows, you see that our team has religiously verified our data, and many other excellent centers, including here Berlin, is verified. I should say that the UK centers have their own separate, for historical reasons, going back to Bristol, so the UK data is not at the moment part of the EXA database, although there is effort to amalgamate the data, and we hope that it will work. Now, what outcome parameters do we measure? Of course, we measure mortality, both 30-day mortality and, importantly, hospital mortality, and we record complications, which include unplanned reoperations, unplanned mechanical support, and complications imparting long-term consequences, such as a stroke or the need for a pacemaker. In analysis, for practical reasons, because there are so many complications, we frequently look at duration of ventilation, ICU stay, or length of hospital stay as a surrogate variable for complications. And in addition to these, there are some other parameters which are still not yet tracked by the EXA database or the other big international databases in North America. And that includes long-term survival, long-term operation or intervention-free survival, and long-term quality of life metrics. I should say that the EXA database, as well as the STS database, have almost simultaneously started recording outcome data at 1 year, which is a very important first step. So the other important point in quality management is that, of course, there is a wide spectrum of diagnosis and procedures, and consequently, there's a wide spectrum of risk. So risk stratification is important. Risk stratification first started as an empirically based effort, where a bunch of experts got together in a room and decided that some procedures have risk A, some others risk B and C and so forth. And that was the basis of the Aristotle system. Perhaps a more well-known system is the RACS risk adjustment in congenital heart surgery system were 6 levels of risk of procedures was thought of by the expert consensus group. And you can see in this table the 6 RACS categories, which, of course, were based on the opinion of experts, but did receive validation by comparison with actual data. The EXA database and also the STS took a different approach and produced risk categories based on actual data. So this was a study combined between the STS and the EXA database, at the time known as the EACTS database, which grouped procedures into 5 categories, which were statistically selected so that the variability within each category was minimal and the variability between categories was maximal. That's the statistical way of defining this. So in risk adjustment, one has to adjust the results for the inherent case complexity, which is, for example, the risk category, but there are also, regardless of the risk category, patient-specific factors, which may include non-cardiac anomalies, chromosomal anomalies, or specific risk factors related to the patient's clinical condition. You may be operating on an ASD, but if the patient is on ECLS because of sepsis, where just a theoretical example, obviously that's a patient-related risk factor. Now, there is important risk factors that we must recognize are not yet analyzed. Some of these are captured, but most are not analyzed. And these include environmental factors, surgeon skill, team skill and experience, center resources, and financial resources. If you then have all of these risks, then statistically it's possible to develop a risk model, which is essentially an equation in which you put the various risk factors and it calculates the risk. And if you do that, and this is from the Annals of Thoracic Surgery and the STS database, a linear risk model is produced. And what you see here is a calculation of the observed mortality and a comparison with the expected mortality for this particular hospital, taking into account the risk of the population operated on. And here are the participant hospitals, and they are sorted by this O to E ratio. And you can see with the error bars, and you can see that these, at this end of the line, you have centers with higher observed compared to the expected risk. And in this end of the line, that's the better end, you have less mortality observed than what would be expected. Now, in the UK, and our UK colleagues, I'm sure, are very familiar with this, a different risk adjustment model has been developed, and it takes into account some parameters, as I noted. Oops, sorry. Some of the parameters noted here. It's a complicated equation, but it does produce a risk-adjusted model. And based on that, there is public reporting in the UK of raw and adjusted congenital heart surgery outcomes. And you can see in this table that I think 11 units that do congenital heart surgery have average risk per case in the order of about 2±%. And if you look at the O to E ratio, or the actual versus predicted survival, I think this, or mortality, then you can see that they deviate very little from unity. And in this table, you can actually see the various hospitals. You can see the blue bar is the expected range of survival. The black dot is the actual mortality. And you can see that it falls for almost all centers either within the blue bar, and in some in the gray bar, which means even possibly better than expected. So this is all very great positive news from the UK. Now, the shortcomings of these methods that are based on linear regression are that they are susceptible to human bias. They assess predetermined relationships between possible risk factors and outcomes. This analysis requires time-consuming study for each separate question posed. And very importantly, this analysis assumes that risk factors interact in a linear way and additive. However, the risk factors are not linear. Body weight has a major impact on a neonate requiring intracardiac repair, but is irrelevant if we fix an AST on a teenager. Or the presence of a single coronary artery may affect the switch operation, but it's irrelevant if we're fixing an AST. So in mathematical terms, this means that the relationship of risk factors and outcome is not linear. With a view to that, the EXA database has launched 2 years ago a cooperative effort with MIT and Professor of Artificial Intelligence, Dimitris Pertsimas, and his group, in order to introduce AI to analyze congenital heart surgery data. And the rationale is that there is no assumption of risk factor linearity, because this method is inherently nonlinear. It is not susceptible to human bias. It's objective. It is capable of very fast automatic analysis and can discover relationships which are not obvious to our clinical intuition. So based on this technology, we have developed risk prediction models leveraging all data from the database and defined the optimal AI-based technique, which is the optimal classification trees. So the risk model is different in this technology. It's not an equation. It presents itself as a decision tree which can be followed. It is understandable and can form the basis for risk prediction of an individual patient. And then we moved to analyzing the outcome of surgery, initially first limiting to the 10 benchmark procedure groups. So these, the results of the 10 standard benchmark procedures, VSD, truncus, switch, and so forth, are obtained by analyzing the tree, and then based on OCT analysis of the aggregate data, the virtual hospital, the performance of a given hospital can be calculated. So from the decision tree of the aggregate data, then we can go to the analysis of the observed to expected ratios for each individual hospital and provide a graphical summary of the performance of each hospital. And you can see in this plane, the green dots represent centers with better than expected aggregate performance. The white circles average or not statistically deviating from average performance, and the red circles centers that may have some need to improve. Importantly, this analysis does not only analyze the overall performance, but it can break down the performance of the hospital as an X-ray view of the hospital and identify cohorts or sub-categories of activity which are better performing or less better performing. In this particular example hospital, you can see that the overall mortality was better than expected, and you can see all the cohorts where it was better than expected, green, and just a couple of cohorts which you can then go in and see that had less than expected performance. And this analysis is broken down by stat category, as you see in the table 1 through 5, and it can also be done by benchmark procedures. I'll just show you, it's easier to show you what this is all about if you watch this very, very short video. Can you start this video for me?
This online platform allows each European Congenital Heart Surgery Association database participating hospital to perform its own benchmarking analysis instantly. The platform is based on the optimal classification tree analysis. The user can select the outcome of interest, mortality, post-operative ventilation time, or length of stay. Here, we choose mortality. Also, we chose to analyze the benchmark procedures in greater detail. Here, the hospital code is selected. Each participating hospital only has access to its own data analysis. In this time frame window, we have selected to analyze the full span of data provided to the database. The analysis presents itself as a decision tree, the branches of which can be followed to the terminal leaves, which define unique cohorts of similar risk. Following the branches step by step makes the logic fully interpretable. At the top level, one sees the overall outcome. Observed mortality is 3.8%. Expected case-adjusted mortality is lower at 3.2%. However, the difference is not statistically significant, and this is indicated by the white color of this box. The decision tree leads to unique patient cohorts, the definition of which is immediately revealed with the cursor and is readily understandable by following the decision tree path. It is clear that while the overall mortality is as expected, there are some patient cohorts with worse than expected mortality. These represent areas of opportunity to improve. There are also cohorts of better than expected performance. These results are further analyzed by benchmark procedures, providing what we call an X-ray view of the hospital performance. It is evident that for the arterial switch operation with VSD closure, the overall performance is less than expected. However, not across the board, but only in these particular sub-cohorts. It is also evident that in this hospital, whose performance is as expected on average, there are not only cohorts of opportunity to improve, but also cohorts of better than average performance, in particular for repair of VSD and for repair of tetralogy of Fallot. Another feature of the online platform, which is quite amazing, is that it allows the user to see trends and examine how these results have changed over time. You can move the slider and limit the analytic window to more recent years. As you do that, you can see that the results are instantly calculated. If you stop here, you only have a 2-year window. In fact, you can fix this time window and then look at the data, how they change over time in 2-year increments. You can see that there was a period where there were many areas of opportunity to improve, and more recently, the results are quite on par with average, except for a couple of minor cohorts. This online platform allows each European congenital.
So this is what this technology can do. As an example, here is our team's quality report. We participate in the EXA database. We do regular data verification. We have recently verified our data. And we obtain a report. First, the EXA overall results indicate for 358,000 procedures, a hospital mortality of 4.16%. And here we get our report, which shows a hospital mortality of 2.48%, and also demonstrates here in the right panel the expected 30-day mortality of 3% compared with the actual 30-day mortality of 2.14%. We also get this automated report downloadable from the database. It's available for every participating center. It shows that you can get the decision tree, the overall assessment of mortality. It's a green box, so you sort of have a color coding, and then you see in the graphs below where one stands with respect to the other hospitals in the database. Now, just a few more minutes, because this is very important. Mortality is not all. There are many perspectives of quality in a congenital heart surgery program. There should be indicators for structure, for process, and of course for outcome, as we have talked about. And because there are other indicators, we have developed in cooperation with the STS a composite quality metric trying to put together mortality and complications, and therefore arrive at a number, a composite measure, risk-adjusted ratio of expected versus observed. This is a paper from a few years ago, which is still very valid. There are multiple quality measures in a congenital heart surgery program. I outlined just a few: participation in a database, having a morbidity and mortality conference, the rate of occurrence of unplanned postoperative mechanical circulatory support or reoperation, and so forth. Another quality measure that has received very important
George,
attention recently.
Sorry for intercepting.
2 minutes.
Please come to your conclusion.
Will come. 2 minutes.
As soon as possible. We have a problem with time.
Technical performance score is a concept that has been developed to assess how well we do this operation. And it is classified as 1, 2, or 3, depending on the severity of any residual lesions. For example, if we operate on an AST, the patient will survive. That's a great success. If we have a 1 or 2 millimeter AST residual, it doesn't mean anything. If we have a large residual that needs reintervention, that's an unsatisfactory technical performance score. It's been developed for the arterial switch operation, and it has been demonstrated that it predicts reintervention. And I think this is an important thing. Finally, there are a couple of other indexes of quality in a congenital heart surgery center. Centers should be involved in education and training and research and innovation. And this is perhaps another field in itself. Atul Gawande, a surgeon from New York, brought this to the public discourse a few years ago. Training is necessary. It should be done in an organized way so that it does not harm patients. And secondly, and I think this came up a couple of times at least, or probably several times during this meeting, innovation and research are critical for progress, and they must be undertaken, but they must be undertaken in a structured way so that patients' safety is safeguarded. So in conclusion, dear Michael, machine learning-based analysis of outcomes is accurate, interpretable, and can assess hospital-specific and case-adjusted mortality, both overall and by procedure categories. The quality improvement program of a congenital heart surgery center must assure that the center possesses the recommended structure, the processes, and monitors these outcome parameters that we have discussed. And of course, the center should be active in education, research, and innovation. It is our moral obligation to ensure that our programs engage in rigorous and objective quality self-assessment along the axis and using the advanced tools available, and that our teams are committed to honest self-criticism and improvement efforts. And I'd like to finish with this. Quality is not something you lay on top of subjects and objects like tinsel on a Christmas tree. It's the cone from which the tree must start. This is not mine, but I like it. Thank you.